Hello, I wanted to quickly introduce this poster entitled CP-GEP Identifies T1a Melanoma Patients at Risk of Sentinel Lymph Node Metastasis. I am Dr. Alexander Mewes, dermatologist here at Mayo Clinic. This particular project is a big collaboration between 11 centers that all participated. First author is the wonderful Dr. Wesley Yu from Oregon Health and Science University. Second author is Dr. Ani Bajava, Research Fellow from our Department of Dermatology at Mayo Clinic. The CP-GEP test is a non-invasive diagnostic model designed for melanoma patients, combining clinical pathologic factors and gene expression profiling to predict the risk of nodal metastasis. It helps identify patients at low risk who may avoid sentinel lymph node biopsy, thus reducing unnecessary surgeries and their associated risks. The test was developed by Mayo Clinic and Skyline DX and has been extensively validated and shows promise in improving patient care by refining treatment decisions based on more accurate risk stratification. I should also say that the gene expression profile is performed on the diagnostic biopsy tissue. At this SMR meeting, there's actually data presented on a very big prospective registry study called Merlin 001, which prospectively validates this test, this CP-GEP model, in an independent multi-center cohort of primary cutaneous melanoma patients who undergo SLNB for standard indications. The PI of the study is Dr. Vernon Zondag, who's the chair of the Department of Cutaneous Oncology at Moffitt Cancer Center, a leading expert in melanoma, and his work focuses on advancing treatment through clinical trials and molecular profiling, among other things. So for this particular study, we included 153 T1a melanoma patients who were all selected for SLNB. NCCN guidelines currently recommend SLNB for T1a melanoma patients if you have certain adverse features such as younger age, lymphovascular invasion, and/or mitotic figures. So for all the patients who were included, we ran the CP-GEP test on diagnostic biopsy tissue, and then patients were binarized as either high risk for metastasis or low risk for metastasis. And then we assessed CP-GEP performance by comparing the probability of having a positive lymph node without any molecular testing, or for patients who were tested low risk versus patients who were tested high risk. And what we found is that if you look at the entire population of 153 T1a melanoma patients, without any further risk stratification, your risk of having a positive node in this particular group was 3.3%. If you were tested low risk by CP-GEP, your probability of having a positive node went down to 1.5%. But impressively, if you were tested high risk, then your probability of having a positive node went up to 15.8%, which is sort of way above the 10% threshold that typically governs who gets who should undergo sentinel lymph node biopsy. So if you only looked at the group of patients who had adverse features as defined by NCCN, so there were 49 of those. For them, if they tested low risk by CP-GEP, their risk of having a positive node went down to 0%. Whereas if they were tested high risk, their risk of having a positive node went up to greater than 15%. And if you only looked at the subset of patients who did not have any adverse features, as defined by NCCN, and they tested low risk, then their probability of having a positive node would decrease to below 2.5%. But if they were tested high risk, then their probability of having a positive node went up to about 15%. So a high-risk test result really indicates that you have a much higher probability of having a positive metastatic sentinel node than if you test low risk. And your risk is above that 10% threshold that you could consider as sort of like a cutoff for selecting patients for sentinel lymph node biopsy. So therefore, as a conclusion, we say that CP-GEP may support the risk stratification of cutaneous melanoma patients with T1a tumors. CP-GEP can support referral for SLNB surgery independent of traditional adverse features. And CP-GEP can identify patients with T1a melanoma who are at high risk of SLN metastasis, who otherwise would not be offered an SLNB based on lack of adverse features. On the other hand, CP-GEP may deselect thin melanoma patients with adverse features who are at a low risk for nodal metastasis. Maybe the last thing I should say is that the distribution of vessel thicknesses in this particular cohort was between 0.1 millimeters to 0.7 millimeters, where the median thickness here was 0.6 millimeters, and the interquartile ranges were 0.5 to 0.7 millimeters. So the majority of T1a melanoma patients included were on like the thicker end of the spectrum of T1a. Yes, so thanks for listening, and if you have any questions, don't hesitate to contact me by email or call me or however you want to contact me. I'd be happy to get back to you. Thank you.